could be us. So back to what I was saying. Could be us.
పొగ తాగటం మద్యం సేవించడం ఆరోగ్యానికి హానికరం. స్మోకింగ్ అండ్ డ్రింకింగ్ ఇంజూరియస్ టు హెల్త్.
సెకండ్ ILO వర్క్షాప్, జోనల్ వర్క్షాప్ విచ్చేసిన CMO గారికి, డాక్టర్ కౌశిక్ సర్కార్ గారికి, GM తివారీ గారికి, మరియు ఇక్కడ ఉన్న HODs, ఆర్థో సర్జన్స్, ఐ స్పెషలిస్ట్, ENT స్పెషలిస్ట్ అండ్ ఆక్యుపేషనల్ physicians and other delegates, Shubhodayam. Now I focus on X-ray interpretation, abnormalities in pulmonary diseases, large opacities in ILO chest radiograph, pulmonary tuberculosis and pneumoconiosis differences. Coming to interpretation of the chest X-ray, first we have, when you take the film, first we have to check the first name, surname and date of the film. That is more important. And next, regarding coming to side, whether it is left side, right side, position, whether it is erect, supine, AP view or PA view. Coming to X-rays, X-rays are observed by different organs of the body differently. Bone has highest absorption, making the X-ray look white. Soft tissue, medium absorption, which looks on X-ray gray, and air have little absorption, which looks black. Normally, what we see in the chest X-ray are manubrium, superior vena cava, right main bronchus, horizontal fissure, oblique fissure, cardiac borders, aortic arch, pulmonary trunk, left atrium, left ventricle, again oblique fissures, diaphragm, etc. We have, for a normal film, we see nine posterior ribs and 7 anterior ribs. Coming to the assessment of the quality, if spinous process is in midpoint between the medial ends of the clavicle, it is normal. If it is either excess either side, we consider it as rotation. For normal inspiration, the 5 to 7 ribs, anterior ribs, should intersect the diaphragm in the mid-clavicular line. To say it's a good penetration, spine should be visible behind the heart. For proper exposure, there is vertebral bodies should be visible very mildly. So this is here, spinous process is midpoint between both medial ends of the clavicle. So it is normal X-ray, normal, we are having normal rotation, no abnormality in the rotation. For penetration, we are seeing the vertebral bodies. For inspiration, 5th to 7 ribs are intersecting mid-clavicular line. Coming to same rotation, rotated film, note the gap between the medial, here we are seeing the gap, this gap. So it is there is rotation. Now coming to inspiration, normal chest exercise, just as I said earlier, we should see 7 anterior ribs and 9 posterior. Coming to picture, ensure important body parts included in the image. Here it is normal. We are covering total body parts in the X-ray, but here we are missing right side. So here we are missing the right side. Now coming to exposure, this is underexposed, this is overexposed. What we see for the exposure is vertebral bodies. Vertebral bodies should be faintly visible throughout. Then it is normal exposure. Coming to systemic approach technique, what we see is A, B, C, D, E, G, H. A is for airways and lungs, B is bones and soft tissue, C for cardiac, D for diaphragm, E for extra body equipment, G for gastric air bubble and hilum, like extra body equipments, pacemakers, foreign body, etc. This is normal chest X-ray with normal, without any rotation, with proper penetration and proper inspiration, everything. Coming to pneumoconiosis, there is no radiographic feature, which is pathognomic of dust exposure. So what we have to, a reader should see is whether the appearances uh, believes or suspects to be pneumonotic origin. We should check only what we suspect or believe to be a pneumonotic in origin. To classify the chest radiograph, we see four main points. One is technical quality, second parenchymal abnormalities, three pleural abnormalities, four is symbols. Coming to technical quality, when everything is X-ray is proper, then we can see good without any rotation, with proper penetration, with proper exposure, we say it as good. Second is acceptable with no technical defects, which impair the classification of the radiograph. Third is acceptable but with some technical defects, that is the technical defects which are acceptable, which won't may not impair the classification. Fourth is unacceptable for classification purposes. The technical quality of the radiograph is not recorded as grade 1 good, then you have to comment why it is not good. Coming to next technical quality over, now coming to parenchymal opacities, we have two types of opacities. One is small opacities, large opacities. Small opacities again divided into round and irregular opacities depending on the shape. Depending on the profusion, we divide it into 0 by minus, 0 by 0, 0 by 1. Coming to 1, 1 by 1, 1 by 2, 1 by 3. 2, 2 by 1, 2 by 2, 2 by 3. 3, 3 by 2, 3 by 3, 3 by plus. Depending on the size, smaller opacities are 0 to 1.5 mm, 1. P or if it is a regular opacities, round opacities are PQR, irregular opacities are STU. But the size, if size is in between 0 to 1.5 mm, we call it as PR. Yes, if size is between 1.5 to 3 mm, we call it as QRT. If the size is more than 3 mm and less than 10 mm, that is 1 centimeter, we call it as R or U. Coming to large, and again depending on the zones, upper, middle, lower zones, bilateral, left to right. Coming to large opacities, if the size is more than 10 mm and less than 5 centimeters, that is between 1 to 5 centimeters, we call it as A category. Large opacities are divided into three categories: A category, B category, C category. A is 1 to 5 centimeters, B is more than 5 centimeters but less than right upper zone. C is more than right upper zone. Just know what I said. So cumulatively, if we have multiple opacities, how to read whether it is a category A, category B, category C? We have to take cumulative, like let us think 1 plus 2 plus 3 opacities. It should, if it is combining three opacities, if it come under 1 to 5 centimeters, we call it as a large A category. B, if it comes under below right upper zone or more than 5 centimeters. C, if it is more than right upper zone. Coming to abnormalities on the chest X-ray, what other than pneumoconiosis? Lungs, we see lung abscesses, pulmonary edema, pneumonia, tuberculosis and lung cancer. When coming to bones, we see fractured ribs, fractured vertebra and dislocation of the shoulder. Whereas heart, we see heart failure, enlarged heart. Other things we see in the chest X-ray other than in the parenchymal lesions are pneumothorax, pleural effusion, like this, aortic aneurysms. Key points: when you read a chest X-ray, you have to compare left side, always compare the left side with right side, upper, middle and lower zones. Decide which side is abnormal. Compare an area of abnormality with the rest of the lung on the same side. Remember, many lung diseases are usually bilateral and symmetrical. Here, lobes, we see the lobes. This is right upper lobe, right middle lobe, right lower lobe. So, upper lobe, right upper lobe and right middle lobe is divided by horizontal fissure, and right middle lobe and lower lobe divided by, this is oblique fissure. This is horizontal fissure, this is oblique fissure. So, this is upper lobe, this is middle lobe, this is lower lobe. Coming to left side, upper lobe and lower lobe is divided by oblique fissure. So, we see here left upper lobe and left lower lobe. This is major fissure or oblique fissure we call it. Coming to lung opacities, we may call it as shadowing. We can call it shadowing, opacification, increased density, increased whiteness are all acceptable terms. Coming to description of the lesion, depending on the size, lesion may be large or small, depending on the side which where it is present, right or left, unilateral or bilateral, depending on the number, single or multiple, depending on the distribution, focal or widespread, depending on the position, whether it is anteriorly present or posteriorly present or seen in the lung zone, etc. Depending on the shape, round or crescentic, again on the shape of the edges, smooth, irregular, depending on the pattern, whether it is nodular or whether it is reticular, net-like, depending on again density, whether it is air, fat, soft tissue, calcium, metal, etc. So, can anybody guess this? Except chest physicians. I request chest physician not to answer. Compare the middle zones. Right. It is air. We have lesion on the left side with air bronchogram. So, a opacity with air bronchogram is consolidation. So, right middle lobe consolidation diagnosis. So, how do you diagnose right middle lobe consolidation? While initial, while I am telling, what I said is right atrium, right ventricle borders we have to observe. So, here right border, that is right atrial edge is obscured in middle lobe consolidation. Consolidation is limited by the horizontal fissure. When I am telling about the lobes, upper lobe and middle lobe is divided by horizontal fissure. So, here limited above by a crisp line formed by the horizontal fissure. So, pathology must therefore involve the right middle lobe. More extensive shadowing also involves the right and left perihilar regions. So, again, I do not repeat, please chest physicians, please do not answer. Again, can you say anything about this X-ray? Can you comment on this? This is cavity. Can you say, is there any another cavity other than what labeled here? Can you locate where? This? Which one? This one? Yes. This is not the cavity. So, usually we miss with, because this is the arterial image. So, this is the opacity, consolidation with the cavity. So, we assume, so we miss that, we misinterpret it as a cavity. This, I hope many will say this. Lung abscess, we see the fluid level, air fluid level. So, this is air, again fluid. So, this is a lung nodule, metastatic lesions. This is also same. Usually, some lesions we miss when it is behind the heart, or if it is in the upper zone behind the clavicle, or it is in the costophrenic angle. Here, a opacity behind the clavicle and ribs, here behind the heart and the costophrenic angle. Comment on this. No, it's not a consolidation. It's a mass with collapsed lung. So this is a horizontal fissure. Shift is there. The X-ray already leaked. We can see here line, visual pleural border, and there is no markings. So when there are no markings, we have to diagnose it as a pneumo with visual pleural border. So this is visual pleural edge and no markings of the lung. Collapse but diagnosed proper. You are right up to collapse, but I need an exact diagnosis. Yes, pneumothorax. So we see the visual pleural border and there is no markings of the lung. Pleural effusion. So for pleural effusion, what we see is the meniscus sign, obliteration of the costophrenic angle and cardiophrenic angle. So left lower zone is uniformly white. There is a concave surface which is called meniscus sign. Left heart border, costophrenic angle, hemidiaphragm are obscured. Slight blunting of the right costophrenic angle indicates the small pleural effusion. Coming to history and diagnosis of the patient with the previous X-ray is a lifelong smoker with weight loss and increased complaint of shortness of breath. The diagnosis is large left pleural effusion with underlying bronchogenic carcinoma. Lobulated peripheral shadowing on the left. There is loss of lung volume, shadowing over the whole lung due to circumferential pleural thickening. Complaints are shortness of breath, right-sided chest pain, history of exposure to asbestos. Biopsy results showed mesothelioma, a malignancy of the pleura caused by exposure to asbestos. This is pleural plaques. Bilateral well-defined irregular shadows that are which are dense as bones, and we see peripheral pleural thickening also. The clinical findings are patient came with shortness of breath. He works in he retired working in a dock. That is history of multiple exposures to asbestos. Diagnosis is bilateral calcified asbestos related to pleural plaques. Coming to again systemic approach, we have dealt with the airway, lungs, air and lungs. Now bone and soft tissue also to some extent covered. Bone or soft tissue lesions can be easily missed if not looked for. Cardiac and mediastinum, important to review size, borders and the mediastinal masses. This is cardiomegaly with pulmonary edema. What we see in the cardiac megaly with pulmonary edema, we see enlarged heart, see for signs of heart failure, upper zone vessel prominence, pulmonary edema and pleural effusions. Pulmonary edema manifests in two forms, interstitial edema, that is septal lines, and alveolar edema, that is in the air space shadowing and consolidation. When the heart is enlarged, it is sometimes possible to determine if a specific heart chamber is enlarged. The heart contour may be abnormal due to cardiac or pericardiac disease, pericardial effusion like that. The heart contour may be obscured by adjacent lung disease, just as we discussed in middle lobe consolidation and other concerns. Signs of heart failure. We see cardiomegaly and upper zone vessel enlargement, that is sign of pulmonary venous hypertension. Next, Kerley B lines, a sign of interstitial edema. This one, air spaces, blunt costophrenic angles. Diagnosis. Septal lines are specific sign for interstitial edema in the context of suspected failure. Other differential diagnosis for Kerley B lines are when there is lymphatic obstruction in the diseases like sarcoidosis, lymphangitis, carcinomatosis. We also see these lines. Generally no more than 50%. Exception is neonates can be bigger. So this is normal only. This is enlarged. Abnormal mediastinum adenopathy seen in lymphoma. This is a case of lymphoma. I hope all will say. Bilateral air shadows under the diaphragm. Diaphragm should be clear and crisp. If blurred, obscured, this should raise suspicion. Here, usually right hemidiaphragm is normally higher than the left, approximately 1 rib space. Clear costophrenic angles. Right-sided effusion cannot see entire hemidiaphragm and have lost costophrenic angle. Yes, this comment on this. Hilar opacity is bilateral. Both hila are larger and denser than the normal. Patient have complaint of joint pain and erythema nodosum. Diagnosis is sarcoidosis. Differential diagnosis is lymphoma, metastatic disease, or infection may occasionally look similar. Pulmonary arterial hypertension may also cause bilateral symmetrical hilar enlargement. Coming to pneumoconiosis, so I want to go into difference between pneumoconiosis and pulmonary tuberculosis. The definition of pneumoconiosis. Pneumoconiosis is a Greek word, pneumo air and conis is dust. The international level organization, according to international ILO, pneumoconiosis is defined as accumulation of the dust in the lungs and the tissue reaction to its presence. What are not included are asthma, COPD, hypersensitive pneumonitis. What is difference between pneumoconiosis and tuberculosis? Both are different in origin, transmission and treatment. Understanding these distinctions is very important. Why means for proper diagnosis, prevention and public awareness, especially in high risk occupational and clinical settings. Pneumoconiosis is also called as black lung disease, miner's lung disease. It is caused due to long-term inhalation of the dust like coal, silica and asbestosis. It affects in the who works in mining industry, construction industry and sand blasting industry. Pathogenesis. When a worker inhales mineral particles which accumulate and causes chronic inflammation leading into pulmonary fibrosis scarring which impair the oxygen exchange, thus leading to the reduction in the lung function. Difference between tuberculosis and pneumoconiosis is it is not contagious unlike tuberculosis. Prevention. It can be prevented by using masks, improving ventilation systems and adhering to workplace safety regulations. Regular medical screening including chest x-ray, pulmonary function tests can help and detect early signs of the lung damage. Tuberculosis. Coming to tuberculosis, it is an infective disease caused by Mycobacterium tuberculosis. It spreads when a patient with tuberculosis coughs, sneezes or speaks, releasing bacteria into the surrounding environment. It primarily attacks the lungs, but it can also affect other parts of the body such as kidney, spine or brain. The symptoms are cough, fever, especially evening rise, chest pain, hemoptysis. The risk individuals are those poor and low socioeconomic middle class people who live in overcrowding, ill ventilated houses and who are exposed to dust also. Here we see the cavitated lesion, pulmonary tuberculosis. Connection between pneumoconiosis and tuberculosis. Though both are distinct, individuals suffering from pneumoconiosis face a significantly increased risk of developing active tuberculosis. The vulnerable reasons are weakened immune system due to chronic lung damage. The local and systemic immunity is compromised, making the body less capable of fighting of infections like tuberculosis. And there is a drainage problem also. Drainage means mucociliary drainage mechanism. So mucociliary mechanism also disturbed. So there is more chance of developing tuberculosis. Many workers exposed to harmful dust may also live in overcrowded or poor ventilated housing. So again, this is also one precipitating factor. Just as we discussed in the risk factor tuberculosis, the workers who work in the factory also live in the overcrowded or poorly ventilated housing. So there is increased chance of tuberculosis exposure for them. Comorbidity concerns. Complicated pneumoconiosis. When last 2-3 slides. When there is coexistence of pneumoconiosis and tuberculosis, we say it as a complicated pneumoconiosis which results in faster disease progression. When there is TB in pneumoconiosis cases, it results in faster disease progression, reduced treatment response and higher mortality rates. Coming to the diagnosis, Tuberculosis is diagnosed by sputum AAB, molecular diagnostics. In contrast, pneumoconiosis is diagnosed by occupational history, radiological findings, and exclusion of other lung disease. X-ray and CT is both common for both pneumoconiosis and tuberculosis. Coming to pneumoconiosis, there is no cure. Management is focused on symptoms relief, slowing the disease progression, and improving the quality of life through oxygen therapy, pulmonary rehabilitation, and avoiding further, this is important factor, avoiding further dust exposure. Coming to treatment of tuberculosis, as you everyone know, anti-tuberculosis treatment. Conclusion: pneumoconiosis and tuberculosis originates from different causes. One, environment and occupational, that is pneumoconiosis caused by environment and occupational exposure. The other is tuberculosis with infection. Take home message: the interest in ways that pose serious health risks, they intersect. Sorry, recognizing their differences and connections empowers better patient care, workplace safety, global disease control. Thank you.